Welcome to this panel to explore the topic of the impact of infectious disease on our industry and what we've learned in the past and perhaps a bit about what has changed as well. Before beginning and introducing the panel members here, please allow me to extend my personal thanks to our host, His Excellency, as well. I would like to introduce our panel. We're very fortunate to have some very significant expertise with us today. Immediately to my left here, we have Dr. Mubarak Aldoub, Consultant Aviation Medicine at the Directorate General of Civil Aviation-Kuwait. And sitting next to him, Dr. Mohammed Wasif Alam, Director, Public Health and Safety, Department, Dubai Health Authority. And Dr. Khalil, Technical Advisor, Team Lead, CAPSCA, Head of Aviation Medicine Department, Civil Aviation Regulatory Commission, was not able to join the panel today, so he sends his regrets.
Yes, Jehad. Jehad. Yes.
And we will be joined by Mr. Jehad Faqir, who is the Head of Safety and Flight Ops, Middle East and North Africa, IATA. And we extend a thanks to him for offering to sit on the panel with us this afternoon. And we're very conscious we're the last panel before lunch, so I'm not sure what we did to deserve that particular honor, but...
Sorry.
Welcome. So SARS and more recently Ebola have been all too perfect examples of global issues that do not fit neatly within boundaries of our industry, and we've heard that theme already this morning, whether that be boundaries of geography or culture or national boundaries. And these crises have sent our industry into turmoil, and certainly there are estimates of the many billions that it has cost national economies, with the world economy in fact, including the billions that it has cost in lost revenue to airlines. And of course, there are lives involved as well, but it is not particularly an aviation topic. It just impacts aviation. And by way of setup and context to the discussion and the questions we have here, I'll give a very short example of something that happened recently at my own airline, which was an incident, actually since I was asked to join this panel, where a single word from an uninformed passenger who suspected a case of infectious disease grounded an aircraft temporarily because of the panic that ensued over the mere possibility. And while our incident was handled through our threat assessment process, I use this example just to illustrate that very few things in our business can strike fear into our community, such as this topic. So with that, we do have some questions we'd like to start with the panel, and I will start with Dr. Alam, if I can. Again, estimated costs to commercial aviation from health issues like SARS and Ebola are quite staggering. But it is a unique issue for us. So why is the impact on aviation for this particular issue so great?
Thank you, Dave. I think he rightly said that the impact of these infection is phenomenal. What World Bank reported that if there were an Ebola-like or this flu-like, severe acute flu-like virus, and that becomes a pandemic, means it is across the globe, affects or infects most of the countries, then it can cause a damage in terms of money close to 5% of the total world GDP. That comes to about 3 trillion US dollar. So you can the 3 trillion US dollar just from one infection, if that's got on board and goes across the whole world, it becomes pandemic. What happened with H1N1, the swine flu? It caused a lot of damage, but it was kind of confined. But if you look at what happened when this SARS infection came in 2003, when SARS came in 2003, it was an infection that people never knew about it. It was something that people were scared so much because they don't know what to do. They don't know where the infection was coming from. And they don't know what are the signs, symptoms, what are the high-risk population, what is the treatment, where should we go, who are the people at risk. So that is the fear of unknown, as Dave just rightly said, the fear of unknown. So that is the reason why, if you do not know the cause, how much damage is going to do us, am I at risk? Is my mother at risk? Is my daughter at risk? We don't know. And we don't know the mortality, we don't know the case fatality rate, that what is the impact, what is the risk of me dying from it? Because it's a new infection. So that is the reason, all these new or re-emerging infectious disease, especially if it's new, it causes a terror. It causes a terror, and that is, if I give an example, if you remember, right after 9/11, the anthrax issue that happens in the US, I was there at that time, and if you experience that, anthrax killed only 6 people. Anthrax killed only 6 people. And out of them, 18 people were infected, but killed only 6 people. But what was the effect of anthrax throughout all the states of cities of USA? It was almost close to a complete shutdown of the government offices. The postal department was almost shut down. People were scared to even open any letter. People were, even if they were going at work, they were talking nothing but anthrax. So much scared. But what's the mortality there was? Only 6% died. People did not know what anthrax is. People did not know what is this causing death. The newspaper, the media was all over. I remember this in one of the hospitals there, when the first case of anthrax came in the USA, in Washington, D.C. hospital, one case. It was announced that, the media announced that that case had been admitted in such and such hospital. Guess what happened? All the patients, the doctor, nurse ran away from that hospital. Because they thought, my God, I will get it. But in reality, you do not get anthrax from person to person. You never get anthrax from person to person. So, but this reality, the information, the awareness was not there. So people so this is the fear of unknown. It happens, it will happen all the time. Any new infection comes in, and in something that is people are not aware of, people will be scared. They don't want to take risk, because I don't know what's going to happen to me or not. I don't know what the treatment is. So I think it is always a problem. It could be a problem.
Thank you, Doctor, for adding color to the context of this. If I may turn to Dr. Aldoub. In addition to the airlines, public health issues can involve many local, national, international stakeholders and authorities, particularly in an issue like this. Can you discuss both the roles of various agencies and as well as the challenges we've seen in the past, and perhaps a little bit about what's changed or what we've learned as an industry in this area?
First, Assalamu alaikum wa rahmatullah. This is an important topic, because after SARS and after the influenza epidemics, people were scared first to fly, and people were blaming aviation for spreading the epidemics or the disease to other countries. So the aviation community with IATA, ICAO, ACI, which is Airport Council International, with WHO, came together and decide on steps how can we minimize the effect of this epidemic or the spread of this epidemic. First, their concentration was on the core capacities inside government work, health promotion, health education, health facilities at airports, and education to the publics. This was effective to somewhat. Now, the problem of people coming inside the countries through airport and other areas, these people need to be screened and introduce the thermal screening, with questionnaire to check if this passenger has possibility or already has infection, and this depends on fever only. Then later, that fever alone is not a good way of detecting the infection spread inside airport, inside countries. Then in the aviation industry, all we know something called GD, or General Declaration. That's called General Declaration of Health. Any aircraft coming to land in any airport had to declare that they don't have any infectious case or infectious condition on board. And this GD at start was saying only fever plus vomiting and diarrhea. That's not enough. We found that is not enough. It could be any gastrointestinal problem can cause this. It's not infectious. So the GD were changed. We have added more to exactly decide whether this is infectious case or not. We have added other items to this. These items are, first, confusion of recent onset. He was okay, then he became confused, plus fever. Coughing, short of breath. And we have added the vomiting and diarrhea, and we have added also skin rashes. So any combination of 3 or 4 of this, then you have to suspect this patient or this traveler may have an infectious case. In this case, also the Aviation Society, mainly with IATA, they have introduced IATA regulations. IATA regulation that help the crew how to first suspect, as I explained, and second, how to manage this situation inside the aircraft. But what about outside the aircraft? Airport that they're going to land with. So, ICAO and IATA and WHO, ACI made a new society or a new authority called CAPASCA. CAPASCA is shortness for cooperative arrangement for prevention of spread of infectious disease through travel. That was the first name which was given to it. This authority or these meetings get together all stakeholders involved in preventing spread of infection through aviation to any country in the world. They sit together and they meet and they decide their regulations and they come to a standard way of dealing with this situation, and this was successful. This is actually started at 2012. But before that, WHO has come with its own regulations. This regulation, as I told you, part of it, they have introduced something called PLF, or Passenger Locator Form. And this form is an extensive form, take details information about the patient, because they used to before that the patient come, they take his telephone number and his address and any complaint, and that's it. It's very difficult to trace them after that. So this form is very extensive, details form, and it's become standard. All airlines should carry this form, and all airports also have a surplus for this. They can supply it to the airline if they don't have it. And this form should be filled by, first, if they discover an infectious case on board, there's a regulation, so that you have a case on board. This case, according to the new GD, is a suspected case. Then cabin crew has to do certain regulation. This regulation, they should move that passenger to the back, to a bulk hold, away from other passengers, if seats are available, with two rows in front of him, clear of any passengers. But if it is congested aircraft, should keep him in his place and dedicated one crew passenger, one crew for the passenger need. He leave the service and he stay with him, take care of him, educate him in what he do when he cough, when he vomit, okay, how to do, where to keep this, and also dedicate one lavatory especially for him. They lock one lavatory for him, for his own use. And that crew should also follow him after he use the lavatory and clean any surface he touch, disinfect any place he touch. And use the PLF for 2 rows behind him and 2 rows in front of him. All these people there should fill also a PLF, passenger locator form, with full details about them, for point of arrival, for the airport at arrival, to be given to the health authority there so they can trace this, because they are contact. They are not infectious now, but they are a potential contact, okay? So they may develop infection later. In this case, it is easy to follow them than previous situation. Also, there was regulation to deal with the hand luggage with him, okay? Because it may be an infectious case. Also, there's regulation that when the aircraft arrive, okay, these people who come to clean the area, they should know where to clean. Clean even the hands, that is his seats, his monitor, any touch he places with a special protective clothing, protective material to prevent the spread of infection to the people next to him, okay? Not only this part, also ICAO came with a new annex, okay, that regulate how the captain in charge, if he discover a case, how he can deal with this by informing the air traffic controller, ATC, of the arriving airport and also of the departure airport, because that case had departed from them. Any contact there at departure airport should be informed, also should be checked, okay? So the next airport of arrival should prepare the health authority that they have an infectious case, suspected infectious case, let's say, and they should prepare the way how to deal with this case. I don't want to take long time, but there is so many things how to deal with this case.
Thank you,
Have time?
Yeah, thank you, Doctor. Yeah, please.
You want me to continue?
Yeah.
I don't want to take other people chance. So once this aircraft arrival, usually it will be taken to a special stand where the health teams comes on board and check the passenger there. Usually they cannot confirm 100% this is an infectious case, but they make the suspicion, let's say, more than 80%, 85%. Then they will take him outside and they'll deal with his situation, or they refer him to a dedicated general hospital. Each airport should have a dedicated general hospital who can go and deal with these cases, and they have a special place for dealing with these cases in the airport. They have an isolation place. This is part of what we call core facilities arrangement. This is for a schedule case, which is was departed from A and going to B. But there is a situation which I'll discuss later, when you are not going to land in B, suddenly your B is away, and suddenly you discover a case, and then you have to land unscheduled, force land to an airport which is not, you are not supposed to land in. There's a situation for this, which was introduced just last year. I was privileged to be part of this. I'll leave it later. But to conclude, now the latest step with Ebola comes in Africa, with mainly 3 countries. We have now stressed on now not point of departure, point of entry, which is arrival airport. Now we have to stress a point of departure or point of exit. Now there is regulation now added that before, why we should check passenger before they depart. So we introduced health measures to check these passengers, why they should be checked before check-in, by thermal checking, by questionnaire, and any suspected case should go to a team, medical team there, to check if they suspect this is a case of potential infectious case. They will not allow him to travel. This is added recently with the Ebola. The 3 Ebola countries now, they practice this. Unfortunately, most airlines in this Ebola events stopped operating to these 3 countries, and they were isolated. And then ICAO came and decided this is not a good practice, and they encourage airlines to do with the introduction of the point of exit checklist. And in this case, I would like to say that at least what I know is one airline is going good business. They did not stop operating to these 3 countries. I'm not a Moroccan, but Air Morocco, continue flying to the Freetown, which is Sierra Leone, and to Liberia, Monrovia. And they used the point of exit screening thoroughly, and they have added also the same at arrival through the Moroccan airport, and it was successful. If you look at the statistic, they have only 1 case missed, okay? But if you look at the time since other airlines stopped operating until now, 1 case in this 9 months or 11 months, that's, it can tell you that it is still safe to operate in this situation from these countries.
So, Doctor, if I may, so that gives a great illustration of some of the things that have been learned from the past experience, with regard to coordination and the update of the protocols and the regulations. If I may, I'm going to switch gears a little bit here, and Dr. Alama, if I may ask, we've been talking about the aircraft and the airports, but even the best protocols may not prevent all cases of infectious disease from reaching a city. So from your experience, what protocols and procedures are in place for suspected cases in Dubai, for example?
Yeah, in Dubai, I can talk about Dubai because I work for Dubai Health Authority. We have a very stringent, very strict policy. As soon as, if there is a case on flight and it's been informed to the control tower, and the control tower, of course, informs the duty manager of the airport, and then the duty manager will call the ambulance. So the ambulance has to go to the aircraft, and they are the people, they're the first responders. They will go to the passenger, and they will briefly do assessment, and then they will bring the passenger to the, we have in the airport terminal 1, it's a medical center. So the patient goes from the aircraft through the ambulance people to the medical center in terminal 1. Now terminal 1, they have doctors there and nurses there, and then they do their own evaluation. And if they think that this is a suspected case, then they will immediately shift through ambulance to, if it's an adult case, that goes to Rashid Hospital. We have assigned a ward for that in Ward 4. It goes directly to Ward 4. It doesn't go through the emergency. We don't want the patient to be exposed anymore. So it goes directly to Rashid Hospital to Ward 4. If this is a pediatric patient, then it goes to Latifa Hospital, and they are informed. So, but before they go, they inform the primitive medicine section of the primary health care, the such and such case is coming. So everybody's ready, because it's not only the suspected case, the contacts of the cases that were in the aircraft and everybody who went through were in close contact, they need to be traced and they need to be followed up. So this is our precaution, our preventive measures that Dubai has taken. It's taken very strictly.
Thank you for that specific example. Just one more directed question, and then there'll be a couple questions for any of the panelists. But again, Dr. Alam, we've been talking earlier about risk assessment. So, you know, in light of that, you know, there's public health awareness programs can be a powerful tool to address threats such as SARS or Ebola. Could you offer your perspective on the balance between prevention through awareness and creating unnecessary or unwarranted fear from a risk perspective? And you touched on the perception issue a little bit earlier. Could you speak a little more on that topic?
Thank you. Here's a tough question. The balance between awareness and the fear, it is a challenge. I mean, how much would you talk about? How much would the public should know about it? You know, but at the same time, you want the public to know so that you can check. But at times, you know, the wrong information goes to the public, and that can be scary, especially again if it is an unknown thing. So how to balance that? I would, you know, the other big challenge that comes is when the news comes from the higher authorities like CDC or WHO, you know, saying that, you know, 250,000 people could be affected, or millions of people could be affected. So everybody's scared. Oh my God, CDC is saying that, WHO is saying that. You know, like they did when which one came? H1N1? When H1N1 came in 2009, CDC said that 250,000 people will die. That was the estimation, based on assumptions. And when CDC takes those assumptions, they take the worst scenario. So they assumed that 250,000 people will die from H1N1. And that was in the news. Everybody was scared. My God, it's me then. You know? But what actually happened, 18,000 people died, not 250,000. All right? So those assumptions and those things, when it comes from WHO and CDC, it is everywhere. And people are so scared. So so how do you balance that? I think it's a big challenge for public health. I mean, for us, I mean, we should not be propagating this kind of news to the public that, you know, the chances of dying is so high. And what we should actually propagate is, how do you prevent yourself? What are the basic things in prevention from such infections? And that is hand washing. Keep the normal etiquettes of cleanliness. Don't touch stuff and then put your hand on your eyes and mouth. Those kind of information, I think, is very useful, extremely useful. If we can convey this to the general public, there is no severe risk for you if you do not cough on somebody's face, if you do not, cough on your hand and then touch objects, and if you wash your hands, you should be safe. So that balance, I think, is very important, and I think as a public health personnel, we need to convey that message and not convey the message that 250,000 people will die, so be scared. Thank you.
Thank you. So a question for any of the panelists. Any thoughts on cultural barriers and challenges in preventing and protecting from the spread of infectious diseases?
If I may continue, because that kind of rolls into the previous discussion.
Please.
Thank you. Is it okay?
Please.
Is it fine? You want to share? I'll go later, no problem.
It's okay.
Go ahead.
No, I just want to,
Go ahead.
before we close, I want our guest, Mr. Faqir, to talk about the capacity arrangement and the stakeholder cooperative work that has been done, and he was part of it in the past.
First, thank you for allowing me and giving me the chance to share the industry experience. I would like to highlight that the safety is our top priority. That includes the health of passengers on board the airplanes. The industry has gained useful experience from dealing with the public health events. This was back in 2003 with SARS, with the avian flu. I recall at that time, one of the airlines, their load factor has dropped to 10% from the total capacity. They were around 70%. And you imagine if this airline, keeps the events was really persisting, and in a month time they will be out of business. So this is very important message for everybody. This requires the collaboration of the airlines, the authorities, and also the public health, WHO, and the ICAO. What we have gained from that experience, we have developed guidance materials that include the maintenance of handling the aircraft. This goes on how to deal with the airplane, what to do after a suspect case arrives, and what equipment they need to change, like the filters, circulating filters. The guidance materials for cabin crew, how to handle the cases on board the airplane, what to do, and the announcements, etc. We had also guidance materials for the cargo and baggage handlers, because they are involved in the business. Based on that, also, we produced an emergency response and action checklist to be used by the air carriers, because a lot of airlines, they lack this kind of checklist. And we developed that, and it's all public available in our website. So anybody can access it and can maybe take it and maybe use it. Now, going back to collaborative arrangement for prevention and management of public health events in civil aviation, the CAPSCA, this is the new name, I think. This is following those kind of events like the SARS and the avian flu. ICAO, in collaboration with the industry, have launched this initiative. This goes back in 2005, 2006. They have rolled out this program in the regions. For the Middle East, this program was launched in September 2011. Now, the doctor has explained all the issues, but I will highlight one very important issue. Part of this collaborative arrangement is to conduct state visits in order to carry out a gap analysis of the airport preparedness. And this was pretty successful in the Middle East. All stakeholders are involved, the IATA, ICAO, WHO, also volunteers who are trained to conduct this kind of gap analysis. A visit takes 2 days for states. They will review the whole requirements. And we found out that many states, they still lack the coordination, collaboration, and communication between the public health authorities, the airlines, the civil aviation authorities, the airport authorities. It is a big issue, and it's a weak link. Now, the public authorities, they develop their national plan for safety. The aviation people are not involved in developing this plan, which is a pity, because they should be involved in the development of those plans. The same thing goes for the aviation national plan, which means if a state has 5 or 6 airports, they need to have a national aviation plan where also the public health authority should be involved, the airport authorities, the civil aviation authorities, even the airlines. And it's still a gap. In the airports, the public health issues, they have to be included in the emergency response plan of the airports, and there were gaps. For the airlines also, they have to develop, or at least measures on the SOPs in order to cope for handling the suspect case on board the airplane. This goes also for the cabin crew. The ATC, air traffic controllers, are involved in the business by also amending their emergency response plan per Annex 11. So it is a collaborative effort that requires the contribution of all stakeholders involved in the business. This is in a nutshell the status for the matter.
Thank you very much, Dr. Faqir. And in the interest of time, I'm just conscious of the time here. I'll please allow you, Doctor, to finish your thoughts on cultural barriers.
Yeah, that was a question on culture, right?
Yes, cultural barriers.
Culture barriers. Well, I think that we discussed this in the previous session where somebody was talking about culture barriers, where we have in Emirates Airlines, for example, they have multinational working in the same airline, which is a challenge, and more so if it's a challenge for the tourists themselves, especially in Dubai, where again it's multicultural. You see so many nationalities, almost all over all places in the world are here, either living or coming as tourists. I would think that in Dubai context, the cultural challenge is because there are a lot of expatriate forces and a lot of labor force here, and if you're talking about the labor force, then we know that they are not well informed, well educated, so they may not understand what is personal hygiene. Say if they have a cough or anything, they will not know even where to report or what to do, and they can spread the infection pretty easily. The other challenge that I could think about is according to the culture here in the region is the family caregivers. The family caregivers, if somebody is sick in the family, is normally the daughter or the son or the wife or the spouse, whoever that is, will come and want to take care. It's not like in the US and the Western world, you just leave it to the hospital and then bye-bye, I'll see you when you are fine. That normally happens. I don't want to insult anybody, but that's what I have seen. But our culture here is different. You have somebody sick, everybody comes in and wants to sit next to that patient, right? And everybody wants to do something. I mean, and if the doctor says, hey, you should not go, you should wear a mask, you should put the mask on your mother. He says, no, nothing is going to happen to me. That's the culture. I don't think if my mother or my sister, even from my culture, if I say, Mom, you are sick, I think you have flu, put a mask on your face. Let me put a mask on myself also. Then I want to go and give you a glass of water. She said, what is this? I don't think it's acceptable to her. And she'll feel like, what is this? So that's kind of pretty strong barrier, if I have to say one, that it pretty prevails in this part of the world.
Thank you. I do want to leave the opportunity for at least a couple of questions, if there are any from the audience. And I'm not, we have a hand up on the right here.
Hi, my name is Megha. I work with 7 Days newspaper. I was just wanting to touch on what you said about perhaps people who are unaware, especially on the flight, and that they have to be retraced or contacted if they were flying with a passenger diagnosed or identified as having Ebola, for example. How does that work, and what risk are you at being on the same plane as a passenger with Ebola, and how does the process work? How do you trace everyone, and what happens after that?
That's a good question, and it's not easy to answer. Okay, in the past, as I told you, usually we take the name and the telephone numbers. But in this PLF, it's even details of who's traveling with him, and where is he going exactly, and his contact in his country, and contact in the arrival place that suppose he is going for a business or whatever. Now, this is not his destination, airport is not his main home address. All of this written in these questions, okay? So, this has to be given to the, as I told you, to the health authority. Health authority can keep this information there. In the past, passengers can move from one airport to another airport where no way we can contact him. But with this, at least we know what is his next travel destination, or this is his final destination, okay? Now, this will be kept according to the disease. The disease, let's say, disease can take 21 days for the sickness to appear, or the incubation period. This will be kept for more, at least 1 week after that. And usually depend on the health authority there. Usually this will be passed to the public health authorities, and in each country WHO has designed or allocated a WHO representative in each country, okay? And this WHO representative should have this information, and he should pass it to the his counterpart on the country, the other country that this aircraft going to end in. So he has the information, and his counterpart has the information. Now, any patient has sickness and he has information that, or he knows that he was in that aircraft, usually they will inform that they were in this aircraft. Or usually we depend that the doctor in charge of him at his destination will ask him, were you outside the country? And this is a routine question, okay? From this, he can trace that country, or he can contact his local WHO, who can contact his counterpart in any other country and get the information. It is not 100%, okay? But it is something being done more than before.
Thank you, Doctor. Anything to add?
Yes, maybe the passenger locator card that they have to fill and pass to the authority. This is what they need to do if there is a suspect case. And it has been modified to new format to be at least easy for the crew and the passengers to fill, because before it was really cumbersome to fill. But the passenger locator card could be a means to trace those people in case they develop, then they can contact them. Thank you.
Thank you. And just time for one more question, if there's another question. Well, if not, I'll leave one last question for the panel, and that is, we've seen several things move through our industry with respect to any emerging threats, and our ability to deal with them moving forward. Any thoughts from any of the panel members on that broad question, Doctor?
Okay. Go ahead.
Emerging new diseases, I think it's a norm. We have to accept that. No matter how good we are in medicine, no matter how much we have researched, no matter what we do, new infection will come, will always come. We can never stop that. So, we have to be ready for that. I'll give you a good example of what is currently happening now with H1N1, the swine flu in India. I think in only 2 months, there have been like 2,000 deaths already. 2,000 deaths from the H1N1 infection, and over 22,000 cases have been identified in only a couple of months. Now what happened is the H1N1, it changed its mutation. There's a little bit change in the configuration of its genes. That has become more potent now than it was before. So these things will continuously happen, no matter what you do, how much you are aware, and how much preventive cares you take. There will always be new infection coming in. There will always be some mutation in the ones that were already had and can be more virulent and can cause more damage. So this is a fight between the infection and the human being. Infection fights to survive, and we fight to kill that infection. So there's always a fight. Sometimes they win, sometimes we win. So it will be a continuous fight, and we can never say that we are safe. Thank you.
Thank you.
Yes. I think what we need to do, based on the gap analysis, we see there are big gaps in preparedness of plans in case of public health events coming in. And it requires the preparedness of that and the means to contain and continue the operation. You need to contain and sustain the operation, not to stop the operation, and this requires definitely well-prepared plans from all stakeholders. So we are in the middle of the way. We don't have this in place, to be frank. There's a lot of work to be done, but these are the most important: how to cope with any emergency, how to manage this and sustain the operations. You don't want to stop the business all day long, but you need to sustain and contain the disease. Thank you.
Well, thank you very much. Anything to
Okay.
last words?
I think I agree with the rest of the panel. There are going to be no more stop for more diseases, okay? But at least if you look at the steps that has been done, we have covered most of area of infection. We're talking about aviation. Point of exit, okay, as much as we can, and inside the aircraft, stakeholders in the hospital, in the airport, ATCs, point of entry, onboard aircraft, and hospital or ministry or health authorities at destination. Definitely, there may be something we have missed, but we will learn by time, as we have learned from previous experience, because we didn't reach that at this step from start. We have learned it from the start of epidemics in aviation and until now. And we will learn more. Definitely, I cannot say this is 100%, but we have tried our best, and we think we covered most of what we can do. But we'll see what's happened in the future, and we will learn, and we can do a measure to rectify any matter that we have missed. Thank you.
Can I add on something? I really wanted to say this. Today's aircraft, I think they are fantastically built in terms of containment of infections. I am yet to see one case where the case got infection from another person sitting next to him. I have not heard one case where somebody got infection from one sitting next to him that has been documented. I'm talking about the serious infection, not talking about common cold and stuff like that. But I'm talking about SARS or H1N1 or swine flu or Ebola or one of those. I have not seen one case that has. And I see the reason for that. The aircrafts as built today, the circulation in the aircraft, as I learned, every 2 minutes, the whole aircraft circulation is changed, the new air comes in. And even the air that I am breathing in is not going to go around through all the cabin. It will sucked up by the very good HEPA system. I think you know better than I do, of course. So the aircraft is amazingly done. So I think the common fear that the general public have, that, oh my God, this SARS is going, I don't want to go travel in that country because there may be somebody sitting next to me and I'll get it. The chances are very, very low, I think. I think chances are very low. And if you just, do a little bit of precaution, be a little alert.
Thank you very much.
Just to say something which is funny, it is fear and panic more than it is reality. Okay, people in the aircraft, once they think that there is an infectious case, people were panic, and it's fear more than the real situation, as I agree with my colleagues here. And in affected countries where they have the epidemic or the disease, it's also life as normal. But people outside were afraid to tell you a secret. It's not secret, I'm just telling. I was in Liberia in this situation, and people, it's life as normal. Okay, sickness around the hospital, around the quarantine area, but other lives are normal. And I was there, I didn't get sickness, and I traveled, I got the screened, and alhamdulillah, thank God, I am okay. So inside that country, the scare of media, okay, media is needed for education, okay, that's needed, but people outside were scared more than the people inside. Inside, it is life as usual. Everybody busy, doing their business, eating, buying, moving around, okay? But outside, everybody think, once I go there, I'm going to be stuck with the business. I'm going to be sick and die. I just want to say that's to conclude my thing. Thank you very much.
Well, thank you very much. And please join me in thanking this expert panel for their contribution.